Welcome to the Vanderbilt Eye Institute's Video Atlas of Retinal Diseases. In this chapter, we'll be talking about pattern dystrophy type 1, and we'll be going into depth on the different clinical presentations, OCT findings, fluorescein angiogram findings, and what can happen in the long term. As a brief review, often the dystrophy is first found in patients in their 40s. Although there can be a delayed onset. It is autosomal dominant, so you will find this in families, and oftentimes there's no history at all because the vision's been good in their parents. The genetic changes are found in the peripherin RDS gene. There's not just one clinical presentation of type 1 pattern dystrophy. We will first start with the classical presentation of a central vitelliform lesion. Then we'll show some other presentations. We'll show some examples of vitelliform lesions with dark centers, some associated with drusen. Not all dystrophies present symmetrically, so you'll find that the use of the OCT and understanding the different patterns on OCT will help you come up with a correct diagnosis. Pattern dystrophy is not a static disease, and you'll see some examples of how the clinical presentation can change with the passage of time. Here is the most common and typical presentation of pattern dystrophy type 1, also known as adult onset BESS or foveomacular dystrophy. This is a 74-year-old who's noticed blurred vision for about 3 years. Her vision is 20/30 in the right eye, 2100 in the left eye. You can see the vitelliform lesions quite apparently, but also note, even though she's 74, there's an absence of drusen and other changing patterns. Here's another common presentation of pattern dystrophy. This is a 50-year-old female with vision of 20/20 in the right eye and 20/30 in the left eye. She has a slightly different but common presentation. Her vitelliform lesion is smaller than the previous patient, and she also has a small spot of pigment in the center of the vitelliform lesion. You can see it more easily on the left eye than you do on the right eye. Sometimes this pigment is best seen with retroillumination at the slit lamp. Make your slit beam small, aim it just off the vitelliform lesion, and you can see the pigment much easier that way. The vitelliform lesions do not always have to have a regular circular shape. The two top photographs are of a 40-year-old male with vision of 20/30 in the right eye and 20/25 in the left eye. The bottom two photographs are of a 52-year-old male. He had been told he had macular degeneration 4 years previously. Beware of the diagnosis of macular degeneration in people under the age of 60. Always have your guard up for that. He was evaluated because he'd had a slow, gradual loss of vision. The vision of the right eye is 20/70 and the left eye was 21/50. Now, if you want to see more presentations such as this, you can go to the GAS Atlas, and there are many other examples of unusually shaped vitelliform lesions. This is a 74-year-old man who's not only have the typical vitelliform lesion centrally, but there's also pigment clumping around the central area of the macula. This pigment clumping could also be a pattern of purulentitis as well as a type 1. We saw this gentleman earlier, but I want to present his angiogram because it shows the presence of drusen as well as the vitelliform lesion. The drusen obviously are seen much easier on the angiogram than you can see clinically. However, we will talk about the specific angiographic patterns in a few minutes. This patient has more subtle yellow changes of pattern dystrophy than in the previous patients. If you look very closely, you can also see a little dark center in the fovea. I brought up this example because of the drusenoid changes in the supratemporal macula that you can see in the left eye. One caution. Remember, just because patients may have pattern dystrophy, it does not mean they're immune from developing age-related macular degeneration later in life. So later on, they may have a combination of both of them, but you do want to be able to notice the pattern and make the correct diagnosis for the proper treatment. The OCT changes in pattern dystrophy mimic the histopathology. Histopathology shows large, round, pigment-laden cells in the subretinal space. It is extracellular material from the photoreceptors and the RPE cells that have been genetically changed so that the byproducts of vision cannot pass through the RPE cells into the choriocapillaris. The OCT findings correspond quite well with hyperreflectivity in this area of the pigment-laden cells. The OCT can be especially useful in asymmetric presentations or unusual clinical presentations, and oftentimes it can give you the correct diagnosis. There are other patterns also that do not show hyperreflectivity, but hyporeflectivity when the vitelliform lesion starts to liquefy, and there are times you can also show changes from choroidal neovascularization. You saw the 74-year-old as our first example in this chapter. She has a typical vitelliform lesion of the adult onset foveal macular dystrophy or type 1. Down below the clinical, you can see an older stratus OCT, but it shows the very typical hyperreflective lesion in front of the RPE and under the photoreceptors. This is our second example that we gave clinically of the vitelliform lesion with the dark pigmented center. This is a more modern OCT, and you can see the same hyperreflective material above the RPE and below the ellipsoid zone. Here's a more magnified view of that patient's OCT. Again, it shows the solid lesion above the RPE. The left eye shows shadowing of the choroid under the vitelliform lesion. These lesions need to be distinguished from drusen and drusenoid detachments, and we'll show some of that later. Again, even though it is genetic and it is a dystrophy, the presentations many times can have an asymmetric presentation, which can get you confused if it's only in one eye. Here's a 79-year-old male who 7 years previously had vision of 20/20 in both eyes. He's now 20/30 in the right and 20/40 in the left. You can easily see the vitelliform lesion in the right eye and some drusen in both eyes. The yellow lesion in the left eye is there, but it is not as well defined and as noticeable. So the question is this age-related degeneration or is it pattern dystrophy? There are pigment modeling, pigmentary changes, and drusen. So the answer may lie with the OCT. And here is the OCT. The right eye shows a well-developed, typical finding of pattern dystrophy with the hyperreflective subretinal spot in the fovea of the right eye. And then the left eye also has the hyperreflective material, but it's just not as well developed. This will give you the diagnosis of pattern dystrophy and not age-related degeneration. This is a 57-year-old female who's on Plaquenil and referred for possible macular degeneration. Her vision is 20/40 in the right eye and 20/20 in the left eye. The vitelliform lesion is seen easier in the right eye, but the left eye looks fairly normal. The fundus autofluorescence shows a little hyperfluorescence in the right fovea, but the left eye also looks fairly good. And here's her OCT. Again, the right eye shows the typical hyperreflectivity under the fovea. The left eye is just about normal, although there's just a slight hyperreflective band, and you can see that very easily between the ellipsoid zone and the pigment epithelium. One more example of how a OCT can help with the diagnosis. In this patient, the right eye has some non-diagnostic RPE changes. The left eye has a very faint yellow lesion with a dark center, and there are also some non-specific RPE changes, maybe some drusenoid changes in each macula. It may be difficult to make a specific diagnosis based on the clinical appearance. She may have had prior inflammatory disease or possible old chronic central serous, just to name a few possibilities. We'll now show the OCT, and that will help you get the proper diagnosis. And here is her OCT. The right eye, I would have to read as normal. You can see the thickness of the choroid is normal, and there are no other RPE changes that you can see on the right OCT. But the left eye shows the typical findings of pattern dystrophy. Other than the typical hyperreflective spot under the fovea, the OCT can show liquefaction of the vitelliform lesion. This patient shows that finding. He's a 70-year-old gentleman with vision of 20/30 in each eye. As you can see clinically, there's a decreased foveal reflex, but the macula is otherwise normal. Here, the fluorescein angiogram shows the hyperfluorescent area in each eye. No drusen are clinically visible or visible on the fluorescein angiogram. Now, in this particular case, this hyperfluorescent center could have you worry about a neovascular membrane, so we'll have to get an OCT to see if that is the case. And here is the OCT. The OCT of each eye shows liquefaction of a prior vitelliform lesion, and we can see this as a hyporeflective area under the photoreceptors. Again, this could be a central serous choroidopathy, and you could interpret it that way as well. But I think that this could be secondary to the vitelliform lesion. Now, actually, we're going to go back in time and show what happens to this patient. So let's go forward in time 7 years on the same patient. Here is a fundus autofluorescence. You can see the hypoautofluorescence in the fovea of each eye, with some surrounding hyperautofluorescence. And here are some more OCTs of that same patient. Now, these OCTs are taken 7 years after the first that we presented. You can see that the right eye has more liquefaction with some hyperreflective areas in the subphotoreceptor area. The left eye also shows some of this hyperreflective material as well. And 5 years after the last set of photographs, you can see the right eye shows even more liquefaction, and the left eye shows the liquefaction and some hyperreflectivity in the middle of the retina, which is most likely some pigment migration. We do not have color photographs at this time. So you can see over time the area of liquefaction has become larger, and in some areas you can see more pigment migration. And now we'll show one more example of how an OCT can help elucidate the diagnosis. This 73-year-old gentleman has had symptoms for over 10 years. And he states he cannot remember the last time that the glasses were ever correct for him. The vision is 20/70 in the right eye and 20/50 in the left eye. He was actually referred for a possibility of chronic central serous due to the pigmentary changes. You can see there's an irregular yellow lesion in the fovea and some surrounding pigment. Here is both a fluorescein angiogram and an ICG on this patient. You can see some hyperfluorescence centrally in the right eye and some diffuse and non-diagnostic changes in the left eye. Neither one has a typical pattern either of age-related degeneration or of central serous. But here, the OCT can really help and give you the diagnosis of pattern dystrophy. The OCT of the right eye shows what could be subretinal fluid from central serous retinopathy or choroidopathy and some irregular RPE under that hyporeflective area. Again, that could be interpreted as central serous choroidopathy or neovascular age-related degeneration. The left eye OCT, however, gives us the diagnosis. Here is the typical subretinal pre-RPE hyperreflective area. Now the right eye makes more sense, showing the liquefaction of the vitelliform lesion and not an exudative reaction. So this slide is just to refresh your memory. We've just seen a lot of subfoveal changes from pattern dystrophy. So let's show some of what the differential may look like. So here on the top left is pattern dystrophy with the pathology at the level above the RPE cells. The top right shows multiple pigment epithelial detachments showing the hyporeflective areas, but these areas are under the RPE. The bottom left shows many small drusen. So again, those are sub-RPE. And the bottom right shows drusenoid pigment detachments. So here you have 4 different examples of pathology at that level of the retina, and I'm again showing this just for comparison. Now we'll go on to some examples of different angiographic findings in pattern dystrophy. This is a 67-year-old male who's had some blurred vision in the right eye for several weeks before presentation. His vision is 20/30 in both eyes. You can see on the color photograph of the right eye, there's some diffuse RPE changes and a little bit of pigment migration centrally. You do not see any drusen throughout the macula. The left eye has even more subtler pigment epithelial changes. Here is his fluorescein angiogram. The left eye on the bottom right just shows some non-specific areas of hyperfluorescence secondary to some RPE atrophy. Pay attention though to the right eye, and this is a fairly typical fluorescein angiographic pattern. There are radiating dark hypofluorescent lines interspersed with radiating hyperfluorescent areas. Now I have this gentleman in my pattern dystrophy folder on my computer, although I could see arguments for age-related macular degeneration, because that diagnosis could be in the running as well. Unfortunately, there's no OCT to make an absolute definitive diagnosis. The angiogram, though, is typical of other patients whom I have seen who do have pattern dystrophy. Again, there's a central dark hypofluorescent area in each macula, and you can see some radiating hypofluorescent lines and some surrounding hyperfluorescent spokes. And again, this pattern of angiography is fairly typical that I've found of patients with pattern dystrophy. We've seen this gentleman on several occasions already, but I wanted to show him at this point to show the pattern of fluorescein angiography. The right eye has a central area of hyperfluorescence, and this is related to the area of RPE atrophy where the vitelliform lesion has absorbed. But note the left eye. Again, here's the typical pattern of the dark center with hypofluorescent spokes, and in between are areas of hyperfluorescence. Again, this is very, very typical of pattern dystrophy. Also note you can see the drusen temporally in the left eye. As mentioned before, pattern dystrophy is not static. It will change over the years, and you should be familiar as to how this clinical appearance can change over time. Here's our very first example of a very well-developed vitelliform lesion in both eyes. This is a 72-year-old gentleman with 20/60 vision in both eyes, and he'd had some mild trouble reading over several years. This is an older stratus, and you can see, especially on the left eye, the pre-RPE sub-photoreceptor hyperreflective area. And you can also see the same on the left eye, although it's a little bit more difficult to pick out the RPE layer on this OCT. Here is the same patient 6 years later. His vision is stable, but you can see that both eyes now have lost the vitelliform appearance and have developed atrophy of the retinal pigment epithelium centrally. The collapse of the vitelliform lesion and the atrophy is demonstrated with the OCT showing the hyperreflective areas in the choroid. We've seen this 48-year-old gentleman previously. The top two photographs represent the clinical picture when he first came in with vision of 20/40 in the right eye and 20/60 in the left eye. 4 years later, you can see in the lower two photographs that each of the lesions have subtly changed. The vitelliform lesion in the right eye has now been replaced by some atrophy centrally. The vitelliform lesion in the left eye has an irregular shape, but no atrophy at this point in time. Now finally, we'll talk about complications. Now, if you want to consider atrophy as a long-term complication, we have already covered that. The other potential complication is choroidal neovascularization. This is a problem in the fovea with changes around the RPE, and there can be damage, and sometimes therefore secondary changes to Bruch's membrane. The next example will be one of Dr. Anita Agarwal's, which is actually found in the GAS Atlas. This is one of my patients who is a 63-year-old female, and she's referred to me with a diagnosis of age-related macular degeneration. She'd had blurred vision in both eyes for several years, and the vision was 20/60 in both eyes. You can see the central vitelliform lesion and some faint drusen scattered throughout the macula. Here is her OCT, and both eyes shows the typical pattern of type 1 pattern dystrophy. 1 year later, she came in complaining of more trouble reading. Vision was relatively stable at about 20/50, but the left eye had dropped to 2400. You can see that the vitelliform lesion in the right eye looks about the same as it did last year, but the right eye is demonstrably different. Her OCT of the left eye also is dramatically different because it shows the neovascular membrane as well as fairly severe intraretinal fluid, which he did not have 1 year previously. She was started on monthly anti-VEGF injections in the left eye. The right eye remains stable at 20/50, and the left eye has regained the vision back to baseline at 20/50. Clinically, you can see that the fluid has dried up, and you can see the pigment mottling much easier this year than you could last year. The OCT also shows that the intraretinal fluid has fairly well absorbed. Just one slide on the genetics, as this chapter here is pretty much of an introduction. You can get this in more detail in any of our great textbooks. The genetic defect is on chromosome 6p21-2, and there's a deletion in exon 3, and it causes a missense mutation of a variety of amino acids in the DNA. It is in the RDS peripherin gene, which encodes specific photoreceptor glycoproteins, and these maintain the photoreceptor outer segment discs. With the missense mutation, these glycoproteins can now not be absorbed and by the lysosomes and phagocytized very well, and this leads to an abnormal buildup between the photoreceptors and the RPE, and that's one of the basic problems with the pattern dystrophy. So in summary, I have found that type 1 pattern dystrophy is often misdiagnosed as age-related macular degeneration. The typical is a vitelliform appearance, usually as a circle, but it can take a variety of shapes. Many times you'll find a dark center, but oftentimes you don't see that unless you put the slit beam just off center and you see that darkness in retroillumination. You can have asymmetric findings, and sometimes the OCT is the only way that you can really give a definitive diagnosis. Pattern dystrophy changes over time, and you can lose some vision, and you can get RPE atrophy after the vitelliform lesion absorbs, and also you can also develop neovascularization. And again, I'll say that just because these patients have pattern dystrophy does not mean they also cannot have macular degeneration, so that is something to keep in mind in the population over 60 who also has vitelliform lesions.